Assalamualaikum. Today we are going to discuss hemolytic anemia in a little bit detail. Uh, the learning objectives of our this lecture will be: we are first going to define what is basically hemolytic anemia. Then we are going to a major classification, its clinical features, and in the end the laboratory findings. And lastly, we will discuss the difference between intravascular and extravascular hemolysis. So, going to the definition first, it can be defined as anemia that results from an increase in the rate of red cell destruction. Hemolysis, when we focus on the hemolytic anemia, the word comes from hemolysis, right? Hemolysis means the destruction of red blood cell. So, in short, we can come up to the definition by looking at this word, that it is the destruction of red blood cell, the hemolysis, basically. Then comes its classification. Two major types or two major classification of hemolytic anemia are the hereditary hemolytic anemia and the acquired hemolytic anemia. In the hereditary hemolytic anemia, there is intrinsic red cell defect, right? There is some intrinsic red cell defect in hereditary, means that there is defect in our genes or chromosomes, or there is mutation in chromosomes, right? That will result in the red cell defect. And as a result of this defect, when the red cell will pass from the spleen, there will be the hemolysis of red blood cell in the spleen, right? After that, we have the acquired hemolytic anemia. It results from the extracorpuscular or environmental changes, right? It is acquired from our environment. Then comes the clinical features. In the clinical features, because of the hemolytic anemia, there is a red blood cell destruction, and as a result of red blood cell destruction, there is jaundice, right? After the jaundice, we have splenomegaly, which means the excessive increase in the size of our spleen. Then comes the pillariness of the mucous membrane. This is something which is common in all the anemias, not specific to this anemia. It is present in all the anemias. Then comes the basic point, differential point, which is present in hemolytic anemia but not present in all other anemia. This is something that normally in the urine, normally there is no urobilinogen. There is bilirubin, but in the hemolytic anemia we have urobilinogen instead of bilirubin. All right. And urine may turn dark on staining because of the excessive urobilinogen, which is colorless, but it oxidizes to a highly colored compound in the presence of light. This highly colored compound in which it converts is urobilinin. All right. Then if there is no bilirubin in the urine, this means that this bilirubin will be in the gallbladder. So it because of the presence of this bilirubin in excessive amount in the gallbladder, it results in the formation of pigments, which then result in the formation of gallstones. All right. Then comes the disease specific complications. These disease specific complications came with the occur with the hemolytic anemia. First of all, I've listed ulcer around the ankle, and this complication is seen in the patients having the sickle cell disease and the hereditary spherocytosis. In the hereditary spherocytosis, there is a mutation in the chromosome which results in abnormalities in the red blood cell membrane structure. As a result, there will be hemolysis in the spleen and vice versa. Then comes the bone deformalities. This complication will be seen in the patients with thalassemia major, as because they receive excessive regular transfusions of blood. All right, there will be bone deformities in them. All right, the third point will be discoloration in peripheral regions. Discoloration in the peripheral region, this is something which is most commonly seen with in the patients of cold reactive autoantibodies. Okay. Then come the thrombosis, which is seen in paroxysmal nocturnal hemoglobin urea patients. Then come the laboratory findings. First of all, I have listed serum bilirubin raised. All right, the serum bilirubin will be raised and there will be no bilirubin in the urine. but urobilinogen will be increased. Okay, then the third point is serum haptoglobin absent. The haptoglobin is a protein which is normally present in our plasma. It is a plasma protein. This plasma protein normally binds with hemoglobin. All right, there will be hemolysis in the hemolytic anemia, means there will be excessive destruction of red blood cell. When there will be excessive destruction of red blood cell, there will be excessive release of hemoglobin in the blood, in the plasma. All right, so in the this plasma protein, uh, which has the ability to bind to the hemoglobin, it will bind to the hemoglobin as it is present more than normal amount in the serum, okay, to decrease this level to the normal. So this haptoglobin will be, all of it will be consumed, because it all of it will be bind with the hemoglobin, so free serum hemoglobin will be absent. All right, then there will be reticulocytosis. All right, then comes the bone marrow erythroid hyperplasia. This occur also because of the red blood cell destruction. When there will be red blood cell destruction, the red blood cell numbers will be decreased. So bone marrow will start increase production of the red blood cell to maintain the normal range. Okay. When there will be increased erythroid hyperplasia, then the bone marrow erythroid amyloid ratio, all right, which is UZ to ratio 1 to 12 ratio 1 maximum, it become 1 to 1 or reverse. Okay, means that amyloids and erythroids become 1 to 1. Their production will become 1 to 1. The peripheral film will show the fragments. These fragments are red blood cells fragments, and then elliptocytes, red blood cells with elliptical shapes are present, and then come the microspherocytes. Microspherocytes are also because of the increased production of red blood cell in the bone marrow. Microspherocytes are, that's why, in the peripheral film. Then comes our last slide, intravascular and extravascular hemolysis. Um, uh, this is something I want to differentiate: intravascular hemolysis and extravascular hemolysis. In the intravascular hemolysis, we find the schistocytes in the peripheral film, whereas in the extravascular hemolysis, we will find the spherocytes in the PF, peripheral film. The haptoglobin will be extremely reduced or it will be absent in the intravascular hemolysis, whereas in the extravascular hemolysis, the haptoglobin will be mildly reduced. Okay, and note that the intravascular hemolysis means inside, vascular means vessels, inside vessel. There is hemolysis inside vessel in the intravascular hemolysis, and extravascular hemolysis means the hemolysis is outside the vessels. All right, the main definitions of both of them. So in the intravascular hemolysis, the haptoglobin levels will be decreased because it is a plasma protein. In the vessels, the blood is present, the plasma proteins are present. All right, so haptoglobin will bind more hemoglobin, and its level will be decreased or become absent even. In the extravascular hemolysis, the haptoglobin will be mildly decreased. Hope so you have cleared this difference. Okay. Then comes the urine hemosiderin, which is highly positive and highly present in increased amount in the intravascular hemolysis, whereas in the extravascular hemolysis, it is negative, is not present. The same like the hemoglobin, urine hemoglobin will be present in the intravascular hemolysis, whereas in the extravascular hemolysis, the urine hemoglobin will not be present. All right, then if we do the drug DAT test, all right, in the laboratory, it will usually be negative in intravascular hemolysis, whereas in the extravascular hemolysis, the drug DAT will be highly positive. The LDH level will be increased in both the conditions as there is red blood cell destruction there. I hope you have learned a lot in this lecture, but if you have any question, you can ask it in the comment section. Thank you for your attention.